very good evening, good morning, and good afternoon to the all the delegates who have logged in this exciting webinar, which has been brought to you by Mumbai Hematology Group and ably supported by Intas Oncology. Today's webinar is quite interesting as uh, two important topics of the disease, which is Hodgkin lymphoma, would be covered by two eminent speakers. This webinar series is the brainchild of Professor Dr. M. B. Agarwal sir and Professor Agarwal sir is an institution in himself and teacher of teachers. Okay, and this is the longest running webinar series in the field of hematology, which has been going on. And what could be better in today's evening, where Sir himself, okay, who is the brainchild behind this webinar series, will be delivering a lecture himself on Hodgkin's lymphoma. So, without wasting time, we would request Sir to take the proceedings forward. Thank you, sir.
Thank you, Mr. Ashish, for those kind words. Let's share my screen. Okay, so even from my side, good evening to everybody from India, and good morning, good afternoon for those who are logged in from the rest of the world. So today we have two speakers, myself, and then Dr. Stephen Ansel, authority on Hodgkin lymphoma from US. I'm going to speak to you on a very interesting subject or aspect of Hodgkin lymphoma, and that is whether we can cure an advanced stage classical Hodgkin lymphoma in merely 3 months. And Dr. Stephen Ansel is going to speak on the management of Hodgkin lymphoma, an update from the ASH 2025, which was just concluded. As usual, these webinars are brought to you by Mumbai Hematology Group. Today's webinar is supported by Intas, Takeda, Natco, and Lucid. It's managed by Perfect Square. I thank Takeda, Intas, Natco, and Lucid for supporting our webinar. Yash Kalpesh and their team from Perfect Square for managing the show. Executive Committee of Mumbai Hematology Group. Our speakers, especially Dr. Stephen Ansel. All our discussants are themselves important and eminent hematologists, medical oncologists, and new participants for sparing your Saturday evening, morning, afternoon. Tomorrow morning, 18th of January, 11:30 a.m. IST, and the Melbourne time 5 p.m., we have Dr. Ashish Bajil, who is a product of India and now a hematologist and transplant physician in Peter MacCallum Cancer Center at Royal Melbourne Hospital, Melbourne, and he's going to speak to us on optimizing the treatment of Ph-positive ALL. Our discussants include many stalwarts, personalities from India and surrounding countries. And their names are displayed here alphabetically. Okay, so we will stop here as far as the introduction is concerned. I'll request our organizers, our event manager to display my slide deck now.
Recording in progress.
Thank you. So the first part of the webinar today is whether we can cure a newly diagnosed advanced stage classical Hodgkin lymphoma in 3 months. So peculiarly, if you look at most of the chemotherapy protocol, there is this surprisingly fixed figure: 6 months, 6 months, 6 months. Anything you talk of, so you give treatment for 6 months. It's a mystery to me. The why not 5, why not 7? Today we are talking about curing Hodgkin lymphoma, and that also advanced stage, in 3 months. I have another question to you. Can you treat these newly diagnosed advanced stage classical Hodgkin lymphoma with progression-free survival, PFS, of as high as 94%, and that too at the end of 5 years of the treatment? That means a mere 6% of relapse rates. And why I'm talking about the 5 years? Because you look at the curve of relapsed Hodgkin lymphoma, majority of relapses occur in the 5 years. After that, there are no relapses. There can be late morbidity and mortality, but that is due to cardiovascular event and second malignancies. The Hodgkin itself, relapses occur only in the 5 years. What it means is that if you've got a progression-free survival of 94% at 5 years, that means probably majority of these patients are cured. So cure is an important aspect of treatment of a cancer, especially when the disease occurs in young people, and Hodgkin occurs in young people. I have a third question. Can you treat newly diagnosed advanced stage classical Hodgkin lymphoma with total dose of doxorubicin as low as 160 milligram per meter square? This figure over here. Very low dose of doxorubicin, and still we talk of cure. And why is this figure important? Because studies have shown that when you use anthracycline in dose about 200 milligram per meter square, there is an increased risk of breast cancer. And this is independent of the age and radiation exposure. In past, we used to say that when you give chemotherapy and radiotherapy, you increase the chance of breast cancer and so on. But here you see the data that anthracycline dose about 200 itself is responsible for breast cancer. So 3 questions. One is treating this disease within 3 months. 2 is almost curing it to the extent of 94%. And third is using a dose of anthracycline which will not increase the risk of breast cancer. Let's look at a case. So you've got Akash, 31-year-old, business executive, married for 4.5 years, having a kid of 15 months. He was to leave to UK for a permanent job opportunity when he got fever, significant loss of weight, and drenching sweats for 3 weeks. PET showed lymph nodes all over, including there was an involvement and metabolically active disease in spleen, liver, lung, pleura, adrenal gland. Biopsy showed classical Hodgkin lymphoma. He had no comorbidities, no habits, no financial constraint. So diagnosis was advanced stage classical Hodgkin lymphoma and our stage 4B. Now, obviously, a young man, he wishes a treatment with the highest chance of cure. And as the job was waiting for him in UK in the quickest time, and who does not want a treatment to last the shortest period of time? So what are your options for treating this gentleman? So the old book will tell you ABVD. And unfortunately, because this is a very cheap treatment from today's standard of Hodgkin lymphoma, it is practiced widely in developing world, including India. And 70-80% or more patients are still being treated with ABVD, which in my mind is an obsolete therapy for Hodgkin lymphoma. First improvement from ABVD came was Rathel ABVD, which was based on that bleomycin is toxic to the lung, can lead to interstitial lung disease, and people can be crippled with the quality of life. And therefore, if your PET scan, this is a PET guided approach, if your PET scan after 2 cycles of ABVD is metabolically negative, you can drop bleomycin. So Rathel ABVD, this was to improve the safety. It didn't increase the cure rate. And as I mentioned, cure rate of ABVD is so small. When I say small, it is still 70%, but from the today's standard of Hodgkin lymphoma, when we say 94% cure rate, this becomes a huge compromise that 30% of your patients will relapse with ABVD-based treatment. So in the world where there is no monetary constraint like the developed world, and in developing world where people can afford, this treatment is obsolete. Germans brought out a very aggressive protocol with a high cure rate, much higher than ABVD, and that is BRCOP or escalated BRCOP, but at the cost of huge morbidity and mortality, side effect profile, which was unacceptable to the world. And outside Germany, nobody used BRCOP. What has happened in the last 1 or 2 decades is the immunotherapy entering the treatment of Hodgkin lymphoma. And the first one was this ADC, brentuximab vedotin. It replaced bleomycin and you got BV-AVD. And a great success, significant increase in the cure rate. And of course, because bleo is out, no lung toxicity. The Germans looked ahead. They realized that this BRCOP and escalated BRCOP is toxic, while ABVD or rather ABVD is non-effective with 30% relapse rates. So they came out with a protocol called BRICARD. And we will see what this BRICARD is. BRICARD is a regimen which takes the safety of ABVD and it produces the results like BRCOP. So wonderful. Enhanced efficacy, less toxicity. And therefore, it has become a standard of care in a large part of the world, and we will see that. Within a year came another immunotherapy, the checkpoint inhibitor-based therapy, the Nivo-AVD. This came from US, so you got your second speaker, we're going to speak about it. And today, probably the standard of care for a newly diagnosed advanced stage Hodgkin lymphoma is between these two last lines, BRICARD, Nivo-AVD. There is, above that, probably everything is obsolete. So what did we do to the Akash? Akash was treated with BRICARD. I will explain you why BRICARD. This is a PET-based therapy, remember. And when I come to Nivo-AVD, I'll tell you, Nivo-AVD is not PET-based. And it cannot be PET-based because when you give Nivo, PET can be false positive. While here you got BRICARD, which is a PET-based therapy. So after 2 cycles of PET, the result was complete metabolic response, Deauville 1. And BRICARD tells you that if you have this, then just give 2 more cycles. That means total of 4 cycles. And 4 cycles means 3 months of treatment. He finished his treatment. He went to UK. He's off treatment for last 18 months. Hopefully, he's cured. Chances of his relapse are very, very small or meager. So that's the beginning of our discussion of BRICARD. I'll show you my case too. This is actually not my case. This is my wife's case, but I'm going to show you because this is amazing case. Shreya, 22-year-old female from Miraj. Chief complaint, same fever, drenching sweat, loss of weight, extensive, massive lymphadenopathy all over, severe cachexia. You can look at her. Poor nutritional status, visible muscle wasting. Biopsy confirmed. Classical Hodgkin lymphoma. High ESR, high LDH, mild anemia. Initial PET scan, bulky mediastinal mass, more than 10 centimeter. And when I come to BRICARD, stage 2B disease with bulky mediastinal mass is included in the trial. But of course, this patient had a stage 4B disease with disease all over. This is her full picture. You can see the tummy because of the spleen and the lymph nodes, and you see the face emaciation. She got BRICARD. It's an OPD-based treatment which is given for 4 days. Interim PET scan of PET2 performed after 2 cycles. Deauville score 1, complete negative. So efficacy of this protocol is phenomenal. Amount of disease which she had, I mean, you could not have imagined that after 2 cycles she will be PET negative with ABVD. But here with BRICARD, it is PET negative. This complete metabolic response allowed us to give just 4 cycles and stop the treatment. So she just got 3 months of treatment, 4 cycles off the treatment. She tolerated it pretty well. There were brief episodes of grade 2 neutropenia requiring GCSF support. There was hardly any neuropathy because she got the drug which caused neuropathy only for 3 months. There was a complete resolution of B symptoms, marked improvement in the nutritional status, which I will show you. Her cachexia was reversed. As of today, January 26, clinical examination, surveillance imaging, no evidence of relapse. She is married now. She has shifted to Mumbai and she recently delivered a baby. That's another important aspect of Hodgkin disease treatment. This is a disease of young people. So when it comes to men and women who are young, the fertility preservation is extremely important. And that was the problem with the German protocol, escalated beer cop and all that. So that has been taken care of by Bricard, which we will soon see. So she got a baby. Now she's employed full-time and works with normal FE case. And that is your Shreya today. Can you imagine the Shreya that time and Shreya today? So that is what cure of this disease produces. My case number 3. I'm not going to give you full case, but I'm just going to show you Mahi Vaishnav, name written here, 22-year-old female. That is her PET scan at presentation. And this is her PET scan, PET 2, interim PET scan after 2 cycles of Bricard. Nothing left whatsoever. This is my ongoing case. She has not yet finished 4th cycle. Soon, I think this month she finishes her 4th cycle. By now, we have given Bricard to 13 patients under own observation and advised it to 8 patients who are taking it under supervision of our colleagues from all over the country. So as I said, today's protocol are just based on 2 immunotherapy. Rest everything is probably compromised. One is on brentuximab and one is on nivolumab. So look at the efficacy of the protocol. You look at the adverse effect profile of the protocol. You look at the ease of administration of the protocol, and you look at the cost, whether the PAP is available or not, because both are expensive drugs. So what Germans did was remodel the BACOP or escalated BACOP to Bricard. This was to mainly decrease the side effect profile. And the chief changes are the backbone of doxorubicin, cyclophosphamide, etoposide was retained. Brentuximab replaced bleomycin and vincristine. Bleo was toxic to lung. Vincristine caused neuropathy, so they were replaced. Dacarbazine replaced procarbazine, so less toxicity to the gonads, so infertility rate significantly comes down. Dexa given for 4 days replaced prednisolone given for 14 days, so steroid toxicity brought down. So this is sort of the protocol. You got BACOP here and you got Bricard here. So you got etoposide, doxorubicin, and cyclophosphamide retained. You got brentuximab, which replaces vincristine and bleo, gone. Procarbazine gone. Dacarbazine enters. Prednisolone gone, and dexamethasone enters. So you've got less lung toxicity, less hematological toxicity, less neuropathy, less gonadal toxicity, less oncogenesis, less problem with the osteoporosis, bones, weight, and infections which happen with prolonged steroid therapy. And that's how you administer. It's given all day 1, 2, 3, all that, and day 5 is oral. So it's a outdoor treatment. Patient comes, takes, and goes away for 4 days. That's the publication, Lancet 2024, assessing the efficacy and tolerability of, remember, this is a PET-guided protocol. So it's a modern protocol, PET-guided, versus escalated BACOP in advanced stage classical Hodgkin lymphoma. It's randomized, multi-center, phase 3 trial. An update on this was presented a month ago, December ASH 2025, which is the final analysis of this particular protocol. So 5 years data. Large study, 1,500 patients in the age group 18 to 60. Again, emphasize it's a PET guided, and again emphasize that if the PET became negative, only 4 cycles were given, so 3 months treatment. So that's what it shows. 2 cycles of Bricard, PET negative, only 2 more cycles. If PET positive, then 4 more cycles. The residual disease, then you give end of the treatment radiotherapy. What about efficacy of Bricard? Is it a compromise over escalated beer cup. And it was a surprise that it is better than escalated beer cup with hazard ratio of 0.66. The blue is for Bricard, the red is for escalated beer cup. So absolute 5-year progression-free survival, Bricard was more than that of escalated beer cup. So this was not thought of, but it was shown. And overall survival was identical, 98% at 5 years data we have now. Now, this is interesting. We are talking about three months. But what percentage of patients needed only 3 months of treatment? 64%. That means 2 out of 3 patients became PAT negative after 2 cycles. So that is why we are talking about 3 months. Side effect profile. So if you look at it, the orange is Bricard, the blue is beer cup. So less anemia, less thrombocytopenia, less infection, less treatment-related morbidity. So less red cell requirement, less platelet requirement, less neuropathy. Less risk of infertility in males, less risk of infertility in females, increased reproducibility, reproduction power with more pregnancies with this. So third point, besides this being a short protocol of 3 months for 64% of patients, having a progression-free survival of 94% equal to cure at the end of 5 years. The third point was the dose of anthracycline. So here, those patients who required only 4 cycles took only 160 milligram per meter square of anthracycline, significantly reducing the risk of breast cancer. So Bricard is associated with increased efficacy, decreased toxicity, superior progression-free survival compared to escalated BFR. So you got a powerful treatment, escalated beer cup, but toxic. So this maintained the power of it for efficacy, and toxicity was significantly reduced. So here you have the obsolete ABVD with 5-year progression-free survival of only 75%. But here you got Bricard and BV-AVD both having 3 years, 5 years. This now we have 5 years data available on Bricard, which is same as 94%. Progression-free survival, which is superior to ABVD. And if you compare BV-AVD with Bricard, another 10% jump from 82% to 94%. So 75% to 80% to 95%. So ABVD, Rathel ABVD, unless you've got no money in your pocket, obsolete. Escalated beer cup, not used even in Germany today. BV-AVD became a fashion till the immunotherapy-based treatment came. So we have Bricard and Nivo-AVD. Now let's talk about Nivo-AVD, which I'm sure our next speaker is going to speak at length, but this is just a gist of it. So the S1826 is a large US-based 3 intergroup study. What it compared Nivo-AVD with BV-AVD. At that time, there wasn't anything else. There was no Bricard. So it's BV-AVD versus Nivo-AVD. 2-year progression-free survival, wonderful. Overall survival, wonderful. However, we still do not have a long-term data. When you're giving a checkpoint inhibitor or immunotherapy of this type to a person who is just young, 20, 25-year-old, you need to know the long-term problems with immunotherapy using checkpoint inhibitor. It caused increased neutropenia, but yes, without risk of fever. There was distinct increase in the risk of immune-related adverse events to the extent of 7% of patients develop hypothyroidism, and we'll talk about some more serious adverse events as well. Because this can lead to autoimmune diseases, patients who already had an autoimmune disease, such patients were excluded from this trial. There is adequate data. I'm not going to go over this slide to show that if you've got a rheumatological problem and if you get checkpoint inhibitor, you worsen your rheumatological autoimmune disease. And you can develop new diseases as well. There are no direct comparison between Bricard and Nivo AVD, but there is this matched adjusted indirect comparison which got published a few months ago. Now let me put that together. So Bricard is PET guided, which is a huge advantage because you can curtail the treatment to 3 months. Nivo, for obvious reason, is not PET guided, so everybody has to have 6 months treatment. 64% of patients in Bricard, treatment will be over in 3 months. Survival, progression-free survival, overall survival, both are equally good. GCSF in Bricard is mandatory. In Nivo, it was not mandatory. Anthracycline dose, we talked enough about it, the advantage over here. While Nivo AVD 6 cycle, everybody will get 300 milligram per meter square. The adverse effects in Bricard basically is myelosuppression. As a hematologist, you are tuned to treating cytopenia, so you're not worried. While in Nivo AVD, there is a big problem. There are immune-mediated side effects which can be immediate and which can be delayed. Some of these can be lifelong. There's no contraindication to Bricard, except probably age-related problem that we'll see later on. But Nivo AVD immune disorders are contraindications. So there are certain hidden problems which have not been cleared in Nivo AVD. And the problem are immune-mediated complications. And these become important because you are talking about young people and cure. When oncologists are using checkpoint inhibitor, they are giving it for a short period because life is short. And majority of patients are elderly because that's for solid tumor. Here you're talking about a 20, 30-year-old man who is potentially cured to the extent of 94%, etc. So you've got a patient who will be alive for the rest of his life, and there can be delayed immunological toxicity. If you don't believe this, then you got to read this blood which just appeared in the blood. 25. Feasibility and safety of anti-PD-1. First line treatment in classical Hodgkin. Do we know the full picture? And the hidden thing is that you can get so many immune-mediated complications. Encephalitis, aseptic meningitis, xerostomia, pneumonitis, liver damage, bile duct damage, pituitary, thyroid, sarcoid, muscle, heart, pancreas, kidney, colon. Going on, hematological toxicity. Just now I lost one patient to HLH. Arthralgia, aseptic arthritis, rash, pruritus, vertigo, scar, myasthenia gravis. My one patient has developed myasthenia gravis after Nivo, and polyneuropathy. And I must mention here, when I talked about pituitary, Dr. S.V. Prasad from Lucknow presented a case of severe hypophysitis. This is severe xerostomia after Nivo. So you name an organ and there can be an immune-mediated complication developing immediately or late. So brain, pituitary, lung, liver, mouth, thyroid, intestine, heart, pancreas, muscles, kidney, adrenal. And there's a published case of Addisonian crisis, and lifelong patient will receive steroid therapy and kidney. There are a lot of unanswered questions with immunotherapy or checkpoint inhibitor-based therapy in Hodgkin lymphoma. How can the adverse effects reporting be improved? What are the patterns of chronic, active, and persistent immune-mediated side effects? What is the impact of acute and long-term side effects immune-mediated? Do the pattern differ between sequential and concomitant approaches? How can we identify patients who are at high risk of these immune-mediated adverse effects? Does anti-PD-1 based treatment impact gonadal function of fertility? So once again to tell you, organs and diseases which can develop immediately or long-term. This is very scary. This is just published in Blood, ITP in patients treated with immune checkpoint inhibitors. And that was the conclusion. It occurred in 1 out of 400 patients, and 30% of patients it recurred if the drug was given again. And there was a higher risk of death. So a lot of work is being done now to see the checkpoint inhibitor and immune problem. This is clinical spectrum and evolution, immune checkpoint inhibitor toxicity over a decade. The word meta-analysis. Same thing again in New England Journal. Another review in Frontier. long-term implications of toxicity, a review. Delayed problem in patients treated with melanoma if the patient survives longer. Persistent problem in health-related quality of life. Thyroid to the tune of 7%. Diabetes mellitus, permanent problem after pancreatic damage. So this is potential delayed immune-related adverse effects in patients of Hodgkin lymphoma treated with pembro with AVD. Fertility and gonadal dysfunction. So immune checkpoint point related hypogonadism, infertility, and neglected issue. There is a fear that probably chemotherapy or Bricard-based protocol or BB-based protocol may not be that safe in elderly people. So this is a study of PET-guided Bricard in elderly people. Again, last ASH. Now, coming outside Germany. So this is an Israel study, a real-world data about Bricard, 63 patients. And the conclusion was the data is identical to that of the research data. And not only it is identical, there was a complete metabolic response after 2 cycles in 83%, not 65, 83%. And less patients required radiation consolidation. So in real life, it was even superior to the research data. Now let's compare. ABVD Rathal, cheapest, so very popular in developing world. 6 months treatment, excellent. It can cure 70% of patients. So that's wonderful. But is 30% acceptable from today's standard? Young girl, college going, comes back to you, 1/3 chance of relapse after giving ABVD, a bit difficult in 2026. BVAVD, definitely a step forward because it improved the cure rates. But still 6 months for everybody. GCSF mandated. Peripheral neuropathy is an issue for 6 months of treatment. And it was not PET guided, so PET must be added. Nivo AVD, huge step forward, no doubt. Superior progression-free survival, better tolerated, less peripheral neuropathy, but not PET adapted, can't be PET adapted because of the false positive PET. Everybody has to have 6 months treatment, and so on. Huge risk of immune disorders, immediate or delayed. You may feel this is negligible. This is not negligible, both in way of morbidity and mortality. So let's compare Bricard with Nivo AVD. Both have got good efficacy, 5-year 94%. So Bricard has got safety of Nivo AVD because Bricard is not escalated BFCOM. Advantage is PET adapted. Advantage is 2/3 of the patient, 3 months treatment. Advantage is these 2/3 of the patient, very small dose of Adriel. And advantage is no risk of immediate or delayed immune disorders. So why should we use Bricard as the first-line treatment for advanced stage classical Hodgkin lymphoma? I would say you should ask, why should we not use? So it raises the bar in classical Hodgkin lymphoma. It's a clear winner. So that's a suggested protocol. So you've got IPS 02 or you've got IPS 327. So IPS 02, you can start with ABVD, 2 cycle. PET2 shows negative, you continue with AVD for 4. It shows positive, you can do Bricard escalation for 4. There's a hitch here. A PET negative, there is significant relapse when you stick to AVD. But that's not the discussion today. I will suggest this as a better protocol. Bricard for all, 2 cycles, PET negative. If there are financial reason, you can de-escalate to AVD 4 or continue with Bricard 2. That's positive, then Bricard 4. I probably prefer this, and therefore my starting point is Bricard for everybody. So that's wonderful. Well, thank you so much for giving this opportunity and listening to me. We can have the slide deck off, and we have a few minutes for discussion. Yes, please. Any questions, or you want to have questions at the end of our guest speaker's talk? Whichever way. But we do have a little time. Any experience? Yes, Roshni.
Good evening, sir.
Good evening.
Up to what age can we give Bricard safely?
So this particular trial was 18 to 60, and I didn't present the data. There is a trial that in elderly people also it is reasonably safe. But elderly people, you may be a little concerned. Fortunately, Hodgkin disease, elderly people amounts to only about 10% of total workload in your practice. But yes, elderly people probably will discuss in the QA, non-chemotherapy approach, pure immune treatment, brentuximab plus nivo or brentuximab nivo with dacarbazine are becoming now very important treatment. So getting rid of chemo. So elderly people, small number of patients, try to be less aggressive. You want to cure them, but you can't cure everybody. Comorbidities, performance status can come in the way. Chemo-free protocols will be more popular. Bricard up to 60, sure.
And how do we diagnose autoimmune hemolytic anemia? And when we give the steroids, how long to give? And whether it would be a contraindication to continue the nivolumab later on?
Yeah.
How should we?
Yeah, good question. So I have a patient who was treated for lung cancer and checkpoint inhibitor, immune checkpoint inhibitor, got severe anemia, referred to me by Dr. Bhavana Parekh. I don't know whether she is listening or not. So autoimmune hemolytic anemia, hemoglobin was 3, frank autoimmune hemolytic anemia, treated with steroid, partial response, gave rituximab, good response. Now maintenance is going on with the mycophenolate and steroid. There is a little bit of hemolysis going on, little bilirubin up, little LDH up, little retic up. I haven't stopped the treatment. So real issues, because some of these diseases are lifelong diseases.
Thank you so much.
You're welcome. There is no other raised hand sign. And in the chat box, there is nothing. Oh, yeah, there is nothing. Well, Dr. Stephen has joined us. So though we are a little ahead of time, maybe we can get on with the next lecture.
Recording stopped.
Good morning, sir. Good morning.
Good morning, Dr. Agarwal. How are you, sir?
I'm good.
It's
How
good,
are you?
good evening to you.
Yes, it is good evening to me. Yes. I will just do little formal introduction. You don't need introduction to Indian colleagues now. We have heard you so many times, but I'll just do that. Okay, so we go on with the second lecture of the day, and we have got an eminent personality, Dr. Stephen Ansel. He has spoken to us multiple times in these webinars. I'm indebted to him, in fact, for teaching us Hodgkin disease and other aspects of lymphomas. He was also personally with us in Mumbai for our conference. He is from Mayo Clinic, Rochester, US, and he's MD, PhD, consultant in the Division of Hematology, Department of Internal Medicine at Mayo Clinic, Rochester, Minnesota. He currently serves as chair of the Division of Hematology and the Enterprise Deputy Director of the Mayo Clinic Cancer Center. He joined the staff of Mayo Clinic way back in 1999, and he holds the academic rank of Professor of Medicine, Mayo Clinic College of Medicine Science. He earned his MB, CHB, and PhD degrees at University of Pretoria in Pretoria, South Africa, where he also completed an internship in internal medicine and surgery, a residency in internal medicine, and a fellowship in medical oncology. He continued education in Johannesburg, where he was a registrar in internal medicine, then came to US and completed a residency in internal medicine, followed by fellowship in hematology oncology at Mayo Clinic. His research focuses on investigating the phenotype and activity of intratumoral T cells and developing strategies to modulate the immune function in lymphomas. Today he's going to lecture us and tell us all about an update from ASH 2025 in the field of Hodgkin lymphoma. So that's his very brief introduction, and we hand over the platform to him. I'll just exit. Yeah.
Dr. Agarwal, thank you so much. Let me just make sure, trust you can see this just fine. So thank you again very much for including me in your program, and really grateful for the opportunity to talk about Hodgkin lymphoma. And as requested, going to be talking about the management of Hodgkin lymphoma. This will be an update from ASH, but what I'll do is I'll put it in the context of managing patients overall. So some of the data will be new, but some of the data will be older. The new data, obviously, in contrast to what we already knew and how this is changing the field. I need to just start off by disclosing that my institution receives funding from these companies for clinical trials, and some of these clinical trials are pertinent to what I'm going to be talking about. So I think for me, it's always very helpful to go right back to the biology and to the histology of Hodgkin lymphoma, and just remind you, most of you will know this, that this is a unique disease. You can see on the top left, there's actually just a very small number, often somewhere around 2 to 5% of the cells that can be seen under the microscope that actually are Reed-Sternberg cells. Most of what you see in the microenvironment around there is actually inflammatory cells recruited to the tumor in response to those Reed-Sternberg cells. And up in the top right, you can actually see the owl eye appearance of a Reed-Sternberg cell. But the important thing just to highlight are the interactions that are happening between this tumor cell and all the cells around it. The bottom two images are really important because it's going to pertain to a lot of the conversation we'll have about new drugs. But on the bottom left is staining for CD30, and you can see these Reed-Sternberg cells are brightly positive for CD30, and all of you know that that is the target of brentuximab vedotin, the antibody drug conjugate that combinations such as Briacad include. On the bottom right is staining right at the bottom for PD-L1 and PD-L2, and that is overexpressed on the Reed-Sternberg cell because of copy number gain and amplification of chromosome 9p24.1. So again, just knowing that biology is important as we think about treatments moving forward. But I think the newer data that I just want to highlight is, while we thought about Hodgkin lymphoma as nodular sclerosis type, lymphocyte depleted, lymphocyte rich types of subtypes, there are more data coming out now that maybe there are going to be different ways in the future to classify Hodgkin lymphoma. And this is actually being done out of the circulation and out of the circulating tumor-free DNA analysis. Going to show you two sets of data. This data is from the German Hodgkin lymphoma study group, now about a year old, but it showed that there were 3 different patterns that could be seen. One that had more of an immune activation appearance, one that appeared to be predominantly driven by viral factors, particularly EBV, and one that was more driven just from genetic mutations. And what was interesting to me, and I might be to you, is that when they looked at the outcome of patients by these different subtypes, they were different. But for me, the most interesting thing is the group that did the worst was the one that I would not have expected, and that is those with an inflammatory environment as detected by the cell-free DNA actually had the worst outcome. And this was despite the fact that about a quarter of the patients in this trial had received a PD-1 blocking antibody. So I think as we're looking to the future, it's going to be interesting to see whether we can actually identify different types of Hodgkin lymphoma based on a non-invasive analysis of the peripheral blood. Similar data also from a year ago from the Stanford group, showing 2 groups that they highlighted here. Some significant overlap because, again, one group was all about mutations and one group was more about an inflammatory environment. And they called these groups H1 and H2. What you can see in the middle of these images is that there were differences in the amount of mutations. Interestingly, the H1 group had a greater mutational burden, but a smaller number of actual cells that were mutated. And then shown in panels D to J are differences between these groups to do with the number of patients as far as whether they were male or female, the extent of their disease, EBV positivity or negativity. But what was interesting right across on the far side is you can see there was actually a outcome difference between the groups. This I don't think is quite ready for prime time yet, but I would just bring it to your attention because as you watch this field, it might be that we can, rather than need to do extensive biopsying, we may be able to identify groups that may have differences in outcome and maybe be treated differently based on non-invasive techniques. So what I'd like to now do is just take you through Hodgkin lymphoma management. We're going to talk about early stage and then we're going to talk about advanced stage. Some of this data is familiar to you, so it'll be a reminder. Predominantly in the advanced stage data, there was information at ASH that is kind of enriched that analysis and that field. And that's what I'm going to share with you predominantly. But I think it's important that we think about Hodgkin overall. So just again, reminding you about how important staging in this disease is. And as you can see from the PET scan in this image here, early stage or limited stage Hodgkin lymphoma is on one side of the diaphragm. And the reason that's important is that potentially the use of radiation therapy can be very useful. Now, obviously, there's always toxicities associated with radiation therapy, although I will stress that radiation techniques are changing, and I'm not sure that is quite the same as it was before, but that's really driven our PET-directed focus in a limited stage Hodgkin lymphoma. So over the years, there have been multiple trials asking the question about, do you really need radiation therapy? And when you do a PET scan, does the PET scan inform sufficiently for you to omit radiation therapy if the patient is PET negative? And so 3 trials that you're familiar with, but I'll just remind you of. The first being the RAPID trial. Patients received 3 cycles of ABVD chemotherapy and then were randomized to either receive, if they were PET negative, involved field radiation or not. And if they were PET positive, they received another cycle of treatment and then radiation. The H10 trial, very similar. Standard arm was to receive 3 cycles of ABVD and involve field radiation. The experimental arm looked to just give 1 more cycle of chemotherapy if PET negative, if PET positive, escalating treatment, and then giving involved nodal radiation. And the HD10 trial, have to stress here, this was in very favorable patients where typically we would give 2 cycles of ABVD chemotherapy and 20 gray as standard. This was looking at whether you could just give the 2 cycles of ABVD chemotherapy. So what did we learn from this study? Well, in the RAPID trial, the outcomes were very good in both arms. They were a little better when radiation therapy was given, but there was no difference in overall survival. So even though there was a decrement in omitting radiation, people felt that it was quite reasonable to leave the radiation out. And in fact, a year ago at ASH, there was a 15-year update showing that overall survival rates were very good and maintained in this study, suggesting that if you did have a slight decrement, it didn't impact overall survival. The H10 trial and the HD16 trial that I'll show you in a minute, both of them actually were felt to be negative studies, meaning that actually omitting radiation therapy was not did result in a decreased outcome. And you can see that shown here. The yellow line are the patients where they received ABVD chemotherapy only, and radiation was omitted, and they showed that in all subgroups, there was a worse outcome, not by much, but by some, when radiation was left out. And the HD16 trial in very favorable patients also showed the same. As you can see, the ABVD only arm in red having a worse outcome. Again, just stressing that the overall survival, however, was unchanged. Now, I just want to put a cautionary note in here because this was our data. So when we saw the results from the RAPID trial in our practice, we said, well, it will be reasonable for us to make a practice change and just leave out radiation therapy in PET negative patients. And after 5 years, we then went back and reanalyzed how we were doing relative to our practice before we made the change. And we were quite shocked to see, as shown in the red, that the chemo alone arm actually was doing substantially worse than how we did before. And this is again where sometimes in your practice, if you let things creep a little bit beyond what clinical trials teach us, you can make sort of decisions that are not favorable for patients. So we had become a little bit more relaxed, allowed some people with a bit more bulky disease to be enrolled and to omit radiation therapy. So when we looked at the data where we were similar to the clinical trials, in other words, the favorable patients, non-bulky, PET negative, then our outcomes looked very good. But as we'd allowed some people with less favorable characteristics and more bulky disease to follow the same path, we actually were showing the data were worse. So again, just a cautionary note to ensure that you keep radiation in the less favorable patients. So what might you be doing instead of radiation therapy? And there are now data, and I'll show you a number of studies where using the new drugs that I just mentioned earlier, so bringing brentuximab vedotin or bringing nivolumab or both into the therapy as a way to utilize treatment instead of radiation treatment. And this was a study, multi-center, published now a few years ago, where brentuximab vedotin plus AVD chemotherapy was given for 3 cycles. In PET negative patients, consolidation was with nivolumab. In PET positive patients, both brentuximab and nivolumab were used, and the outcomes were outstanding. So again, the number of people requiring radiation in this study was nobody, and I think that, again, this is a strategy to have a better outcome if you utilize these new agents. The German Hodgkin lymphoma group did something different, but they actually left the radiation in, but they brought nivolumab into the combination upfront in early stage but unfavorable patients. And what you can see here is outstanding progression-free survival curves. They had 2 groups. They had a concomitant where they gave nivolumab and AVD together, and a sequential arm where they gave nivolumab first and then brought the AVD chemotherapy on at the back. Both groups of patients did receive 30 gray of involved site radiation treatment. But the point here to make is that those progression-free survival curves are so good, I don't know how you improve upon them. And that would suggest that this kind of new agent plus modest radiation brings outstanding results to patients. How about if you just took all the drugs we have that we know are effective and used them all together? How could we do, and would that then allow us to leave radiation out of our mix? And here you can see brentuximab vedotin plus nivolumab, and then just the most active drugs from the ABVD combination, which is doxorubicin and dacarbazine. And this was a multi-center study, and again, a very good overall response rate in patients, and this response rate looked very durable. In this case, about 93% complete response. So what do I hope from limited stage patients are you taking away? And the question is just radiation therapy or not. I will say this much, that PET-directed therapy is feasible. It's what we do in practice, but there are some caveats where I think we just need to be careful. PET negativity, often in our thinking, is to omit radiation treatment, and that's feasible, but remember it needs to be in very favorable patients, and it needs to be in patients without bulky disease. In PET2 positive patients, it does seem that escalating treatment in those patients does improve outcomes. So my view is that when we're leaving a radiation just kind of without thinking about it too much, be careful, because as we showed in our data, if you do leave radiation out in patients with more bulky disease or unfavorable characteristics, you may actually have worse outcomes. I think in those cases, proton beam therapy or clinical trial approaches using new agents would be preferred. So now we're going to change gears and talk about advanced stage Hodgkin lymphoma. And then at the end, we'll come back and we'll talk about relapse patients. But in advanced stage patients, at ASH this year, there were a number of updates around important clinical trials. So first thing, obviously, is brentuximab vedotin has been around a long time. We've been utilizing that in the BRIACAD regimen, and we used it previously in the brentuximab vedotin AVD strategy. Again, everybody in this on this call is familiar with it. that it's a drug that binds to CD30, gets internalized, MMAE, which is the payload, binds to tumulin and arrests the growth of the cell. And you can see the image I showed you earlier that this targets mainly the Reed-Sternberg cells, but I will say this much, that MMAE may also then be released into the microenvironment and kill off macrophages and other cells which are unfavorable in Hodgkin lymphoma. And all of you would know that the results have been very good with brentuximab vedotin plus AVD chemotherapy in comparison to a BVD chemotherapy in advanced stage patients. Shown on the left is the improvement in progression-free survival, and notably and surprisingly, an impact on overall survival over time. And I think that does speak to how brentuximab vedotin may actually impact an early precursor cell, which may actually change the biology of Hodgkin lymphoma substantially. In the German Hodgkin lymphoma study group, they took brentuximab vedotin and incorporated it into the BRIACAD regimen. You would all be very familiar with that. This allowed them to decrease some of the toxicity seen with escalated BIACOP, help the treatment be more well tolerated. And so the HD21 trial compared BRIACAD to the standard escalated BIACOP, and you would all know that it was PET directed. So if you were PET negative, you would only need 4 cycles. If you were PET positive, you needed 6 cycles. But the comparison showed 2 things of importance. Number one, that BRIACAD was definitely better tolerated with fewer side effects. And then, really encouragingly, BRIACAD actually was better as far as progression-free survival was concerned when they were looking at the 3 and then 4-year progression-free survival estimates. So at ASH this year, there was a further update. This was now the 5-year update of the HD21 trial. Again, the hazard ratio for progression-free survival substantially favors BRIACAD, and the PFS is actually 94% compared to 91% if you look at BRIACAD versus escalated BIACOP. And particularly in the PET negative patients, the results actually were pronounced with a progression-free survival of 96% compared to 92%. I think 2 things that were important additional bits of information that came from this presentation in December. The first was that metabolic tumor volume at baseline, when one used these regimens, was not actually associated with outcome like we might like. And it was more the traditional variables like male, sex, and hemoglobin and the like that were part of like the Hassan-Cleaver index that were associated with outcome. So again, I think there's work to be done to really utilize metabolic tumor volume and work out how best to use it in this setting. The second thing that I think all of us are always interested in is second primary malignancies. So now with 5 years of follow-up, the second primary malignancies in the escalated BIACOP cohort was 2.1% and 2.8% after BRIACAD. So I think the takeaways there were not different between the 2 groups, but not very high in either of the 2 groups. So I think that's important information. Second new strategy that everyone is now utilizing in their treatment is the use of PD-1 blockade in Hodgkin lymphoma. And I show you the same images across the bottom that I showed you earlier about how the copy number gain amplification is driving overexpression of the PD-L1 and PD-L2 ligands. And everybody knows that nivolumab and pembrolizumab and other PD-1 antibodies are highly effective in Hodgkin lymphoma and have now been incorporated into frontline therapy. So this data was published in the New England Journal of Medicine a year and a half ago. This was the comparison of nivolumab AVD chemotherapy compared to the brentuximab AVD chemotherapy. And you can see reported at that point was the improved progression-free survival at 2 years of 92% compared to 83%. There was some discussion at that point about how the curves were beginning to kind of trend back down toward each other. And so that's why, again, at ASH this year, there was some update now out at 3 years. And this is the data now at the 3-year progression-free survival. And I think what is very encouraging is that kind of trending toward each other now seems to not be true. And you can see the graphs stay separate with a 3-year progression-free survival for nivolumab AVD chemotherapy of 91% compared to 82% in the brentuximab vedotin AVD chemotherapy. Questions that had come from this trial was to say, well, is this difference only true, for example, in the elderly, or only true in pediatric patients? What about if you're doing a comparison with, at least in your mind, with Brentuximab, with the BRICAD regimen, which really focused on the 18 to 60-year-olds? How does this all stack up? So the data at ASH showed now each of these groups. So this is the adolescent patients, those that are under 18, and you can see the 3-year progression-free survival looks excellent. Nivolumab AVD at 93%, 82% for brentuximab vedotin AVD in the younger patients. In that middle group, the group where obviously most comparisons to BRICAD are being made, there is still an advantage. Not quite as impressive though, but still 91 versus 85%, as you can see in the image here. And then I think an area in which there is really the most dramatic difference, and I think the thing that has impacted practices quite most substantially, and that is that the nivolumab AVD chemotherapy was significantly improving progression-free survival of older patients, those over 60 years of age, as shown in this slide. Then I think additional information that was discussed was, is it true across all of the risk groups? So is it true in low-risk patients, IPS, for example, 0 to 3? Is it true in IPS 4 to 7? And again, you can see in both of these cohorts, the effect is true. The effect appears to be most profound in the lower-risk patients, but I think you can say those curves separate pretty remarkably in all patients across the board. So I think, again, in North American practices, nivolumab AVD chemotherapy is now really the standard of care and has shown benefit in virtually all groups, well, not in all groups, including all risk groups. So I wanted to take a minute to then highlight the IPS data, because right after the presentation on the randomized study comparing brentuximab AVD to nivolumab AVD, was a discussion about modifying the IPS score using what is called the AHIPI, which is the Advanced Hodgkin International Prognostic Score. And this takes us way back to 1998. This was the original IPS publication, showing that if you have a number of these clinical variables, each having another one of them decreases your outcome quite profoundly. However, as treatments have got better, you can see that the differences between these groups have kind of become less clear. And while there is a difference between the very highest risk and the lowest risk, that has kind of begun to weaken its prognostic and predictive ability. So this AHIPI is really taking the same variables and using them in continuous fashion rather than dichotomizing them. And that's really just a simple little app that you can use. You can see the QR code at the top. One can just download it, or alternatively, just go to hodgkinsconsortium.com. And then what you just do is you just dial in the exact age of the patient, you dial in the exact lymphocyte count, the exact hemoglobin, and the exact albumin, and it calculates for this particular patient, that patient's exact risk. And you can see the 5-year progression-free survival and the 5-year overall survival can then be exactly determined. And how is this then important? Well, they took that AHIPI and applied it to the data I just showed you in the S1826 trial. And so you can see if you were to take high, which is higher than the median, or low, which is below the median, and applied either the IPS or the AHIPI to the data you just saw, you can see that the IPS, the standard, really only differentiates very modestly, whereas the AHIPI is a lot better at really showing outcomes that in a more definitive way. And then what they did was they said, well, is this true for all treatments? So they took the nivolumab AVD arm, and then they took the brentuximab AVD arm, and you can see that across the board here, it was very good in distinguishing higher risk versus lower risk patients. So I think, again, just in your practice, that's the same standard prognostic variables that you use, but just being used now in a continuous fashion provides more information. So just with that information in the background, thinking about how this is moving forward, Just one more piece of information for treating patients with advanced stage classical Hodgkin lymphoma is how about you just took all the drugs again, put them all together? What would that result look like? Well, we only have a limited data here, and it hasn't been updated for now a year and a half. But this was taking brentuximab vedotin and nivolumab and doxorubicin dacarbazine, the most effective agents, and using them all together. And you can see promising response rates, a good-looking progression-free survival curve. But to really know if this is better, it's going to require a randomized trial. So what do I think? If you're thinking about frontline treatment outside of a clinical trial, what would I recommend, or what would I do in my practice? I think if you have early stage, particularly favorable patients, if they are truly very favorable, in our practice, we would do 2 cycles of ABVD chemotherapy, and we would use 20 centigrade of radiation therapy. And this is really focused again on the very favorable low burden patients. In patients that have more disease, unfavorable disease, we would typically consider utilizing a PET approach and omitting radiation, but being very careful to avoid doing this in bulky patients. In patients with more higher risk disease, we would favor doing this in low burden. And obviously, if you're going to radiate the breast in a female patient or the heart in a patient, that's a reason to consider not giving radiation treatment. And then I think across the board, the advanced stage patients, nivolumab AVD chemotherapy and Briacad are the 2 treatments of choice. Still trying to tease apart the best approach. I think in my head, lower risk patients, the elderly particularly, nivolumab AVD chemotherapy is very well tolerated and the results are really very good. I think in higher risk patients, Briacad may be a better choice and maybe another place for that to be considered. So I'm going to take just the last few minutes of our time today and talk now about relapse patients and talk about kind of standard approaches and how that's impacting therapy, and then talk a little bit about a new drug trial that was presented at ASH and the promise for the future. So again, if you're thinking about a patient who's gone through any of these frontline treatments and then has disease progression, this field has kind of moved around a lot because we used to use brentuximab vedotin standardly in frontline. That really then made it difficult to know where to utilize, for example, brentuximab vedotin later on, like post-transplant. But we would typically use PD-1 blocking antibodies as second line. If you received a PD-1 blocking antibody in frontline, well, then again, where do you use PD-1 blocking antibodies subsequently? So I think your choice of second line treatment is driven entirely by what you did in frontline. But here are important pieces of data that would inform your decision. So in patients who have progressed and need salvage treatment, pembrolizumab plus GVD has been a very effective regimen that I think is incorporated into many people's practice. And this was a small study, but the overall response rates were very good and the complete response excellent. So that was 100% and 95%. And patients who then went on to transplant, which was pretty much everybody, had a very good outcome. Similar data was shown with nivolumab plus ICE chemotherapy. Again, with a very high overall response rate, the majority of patients being able to go on to an autologous transplant. And just showing the curve here where the 2-year progression-free survival is in the 75% range. If you cast your mind back to what we used to expect from ICE chemotherapy, it was more in the 60% range. So clearly a substantial step up from what was typical. Data that was just actually came out in Blood just a few weeks ago now took a lot of the data to say which combination should we use. And this was a multi-center, multi-agent retrospective analysis. But you can see 3 groups of patients who in the blue line received a chemotherapy-only salvage, patients in the black line who received a chemotherapy plus brentuximab vedotin salvage, and the blue line at the top being a patient who had a checkpoint inhibitor included into their salvage regimen. And you can see a substantially better outcome when an immune checkpoint blocking antibody was added to the salvage treatment. So my recommendation to patients, and I'll touch on this a little later, is that if you have not received a immune checkpoint therapy before you get your salvage treatment, you should definitely receive that. And even if you have, and it's not a case of you had primary refractory disease, but you responded and then subsequently relapsed, we would add a immune checkpoint to your regimen to try and replicate this result. In patients who then receive salvage treatment, proceed to an autologous transplant, this had been a space where it was a little complicated to know whether consolidation with brentuximab vedotin was needed. And data now that it's now almost 10 years old had shown that if you'd never received brentuximab vedotin and then you received it post-transplant in high-risk patients, including those that were refractory to initial treatment, those who relapsed within a year, or those that relapsed with extranodal disease, in all of these groups, the addition of brentuximab vedotin made a difference to improve the progression-free survival. So when we were doing a lot of brentuximab vedotin in frontline, then that made this a little more complicated. But as our practices in the US particularly are evolving, and nivolumab AVD is typically used in frontline, we are very typically doing this again post-transplant in patients who undergo an autologous transplant because they would not have received brentuximab vedotin until this point, and if they are high-risk patients, they may substantially benefit. So now taking you to patients that have actually had frontline treatment, salvage, transplant, and yet again evidence for progression. Older data that just says that in that circumstance, if patients have not received a PD-1 blocking antibody or have not received brentuximab vedotin, a comparison of those two, which was pembrolizumab versus brentuximab vedotin, showed that pembrolizumab was superior as far as progression-free survival is concerned. So this is always complicated by what has been received before, but important to know that if you've not received a PD-1 blocking antibody and you're at this point as a patient in your disease journey, this is the time to receive a PD-1 blocking antibody. Now, just to say, most of us, that's kind of typical practice. The biggest challenge many of us are having now is patients that have had all of these therapies, have received brentuximab vedotin, or have received pembrolizumab or nivolumab as part of their regimen, and now have disease progression. What to do moving forward? And so just a little bit of data that says that there are other strategies that are becoming available or may be available in the future that could be very valuable. So the first is to say, could you add a second immune checkpoint? So in this case, this is the use of an anti-LAG3 antibody. LAG3 is another immune checkpoint that has to do with immune exhaustion. And this shows that when you add pembrolizumab in patients that had failed PD-1 blockade, who now get continued PD-1 blockade, but also a second checkpoint, favrelizumab, the response rate here was about 30%. You'd say, well, 30% doesn't sound that great, but just to point out to you that the waterfall plot shows that the majority of patients had some degree of benefit. So in patients where the goal now is really kind of just trying to control the disease, this is actually a promising result. Data that was just presented at ASH this year, which I think is also worthy of looking at, is a different way of targeting the CD30 molecule. So this was a CD30 directed antibody drug conjugate. This had a topoisomerase inhibitor as the payload. A study of 50 patients did include other CD30 positive lymphomas, but when you looked in at the 35 that had Hodgkin lymphoma, the response rate in patients that had received brentuximab vedotin before was 76%, with about, with a modest CR rate, but again, a great substantial control of the disease over time. And ctDNA actually proved to be quite useful to work out whether patients would durably benefit with a greater magnitude of reduction in ctDNA associated with a better and more durable clinical response. So I think we're going to see other CD30-directed drugs with a different payload due to the fact that that is a good target in patients with Hodgkin lymphoma. And then finally, just some older data, but just to say this remains a little tricky and I think is something that we're watching with interest. And that is a CD30 directed cellular approach. So this was the CD30 directed CAR T cells. There have been a number of studies. This is an older one that I'm just highlighting here. And the reason I highlight it is that overall response rates with this approach is actually quite good. The biggest problem is durability is very short. And so it's not clear that these are effective ways in keeping the cancer controlled for the long term, quite different to what we see in B-cell lymphomas. So I think we've got work to do to work out how to utilize CAR T cells in Hodgkin's to get durable results. One way that we might be able to get durable results, because we may be able to give more than one infusion, is utilizing allogeneic cord blood derived NK T cells. So this was a study where the NK T cells were pre-activated and then pre-coated with AFM13. So those who don't know what AFM13 is a CD30 CD16 bispecific. So it's a bispecific but doesn't target T cells. It targets NK cells and monocytes and macrophages. So by pre-coating NK cells, it was almost like one made a NK CAR and then infused this into patients. And I think what was encouraging here was that the overall response rate was 93%. CR rate was in 2/3 of patients. I think, again, the challenge here is that the responses were not as durable as what one would like. It wasn't clear that lots of patients were being cured, but this is a strategy that one can do more than once, and so therefore that may be the promise for the future. So in relapsed Hodgkin lymphoma, what would I say are important lessons that we can learn from the data that's available right now? What you do subsequently should be very much determined by what you did initially. So just whatever agent you used up front would help you then determine what you should do subsequently. However, if you have a patient who has not progressed on a PD-1 blocking antibody and is now relapsing and needs to go receive salvage treatment and go to transplant, typically adding a PD-1 blocking antibody to a salvage chemotherapy regimen, and we often use ICE in our practice, that would be strongly recommended. And as mentioned before, a salvage regimen really should contain a PD-1 blocking antibody unless the patient just progressed straight on it right before. What about consolidation post-transplant? Well, in our practice, where we're using less brentuximab vedotin initially, we're now using much more brentuximab vedotin in high-risk patients post-transplant as consolidation. And should you in consolidation use the same drugs as you used before? I don't know that there's a lot of value in that space. I would instead keep drugs in reserve in case you need them at a later point. So takeaways I hope you heard from the presentation. Utilizing these new agents in initial treatment, I think, is now the standard of care. Briacad and nivolumab plus AVD chemotherapy are the two treatments of choice. Still unclear at this point as to exactly which one is better. I think both of them are excellent, and it really depends on your level of comfort with the regimens and your resources as to which one works best for you. In the relapse setting, PD-1 blocking antibodies being added to salvage treatment prior to transplantation is strongly recommended, and using brentuximab vedotin as consolidation if you didn't use it before post-transplant is also recommended. And then if you have clinical trials available to you, please participate. And the reason that that's important is we need new agents in the post-transplant failing patients. And so really contributing to that will be invaluable. So with that, I'll thank you for your time and attention. I know there are others that have comments, and I'd love to take any questions.
Thank you, sir. Great review and update. Enjoyed listening to you. So we will have questions from our colleagues, but I'm going to ask you one very, not very important question from your angle, but from our angle. ABVD cured 70% of patients. Is there a way to pick up those 70% before we introduce these costly agents in treatment of all the patients here?
Yeah, so that's actually a very good question, and I would say that's a very pertinent question, because you're dead right. ABVD chemotherapy will cure at least 3/4 of patients. I would say that what we know so far is that patients that are relatively low risk as far as IPS is concerned, and patients that have a PET negative result after 2 cycles of treatment have a very high likelihood of being in that group. So I think that may be a way to be able to already start to distinguish who could benefit from ABVD chemotherapy alone. Obviously, if you're doing well with the ABVD chemotherapy and you are PET negative, omitting the bleomycin is useful also to avoid toxicities. One of the things I'm excited about and that was presented at ASH that I didn't discuss, but I think is going to be a future, is the use of AI to look at just the H&E image and predict the likelihood of a good response to ABVD chemotherapy. Because it might be that your pathologist can just simply upload the image and then get a likely to be in good shape post ABVD chemotherapy result, which could really help us drive patients toward more standard treatment and avoid expensive drugs in a way that's much more quick and efficient and can be able to get data to you, the practicing person, as quickly as possible.
Thank you. I'm going to ask you one more question. In a limited stage disease, from your talk, I understood one thing, that if PET is positive, radiotherapy becomes a must. If it's an unfavorable disease, radiotherapy becomes a must. Am I right?
That is correct. And I think, again, I'm a little bit more in the camp of saying, in the past, we gave radiation therapy a bad rap. We were all like, when I want to give radiation treatment, I think we actually compromise the outcome of patients when we make prejudicial statements like that. I think, as you point out, the data would strongly support that if you have a PET positive patient or if you have a patient with high risk disease, poor prognosis, more bulky, those patients should definitely receive radiation treatment.
And one last question from me. Once you have used this PD-1, etc., and you get a positive PET, now how do you interpret that?
I think, to be honest, we've always struggled with this over the years. I will say this, when I look at PET scans, there are differences in how it looks when a PET scan is positive from inflammatory changes from PD-1 blockade and from disease. If you've got a big mass in the mediastinum and that thing has gone away completely, and there's a little thing that's gone positive in the armpit, that's not active cancer. The cancer is much, much better. So we are kind of learning just what really looks like, active disease versus not. However, if in doubt, I would strongly recommend biopsying so that you know for a fact, because sometimes you can make mistakes. Or otherwise, one other strategy that does help is just to wait sort of 2 months and repeat the PET scan. All things become evident once you give a little time.
Thank you. Thank you. Roshni, your question.
Good evening, sir. The first question is very basic. What is that? How to define favorable risk?
Yeah, so we generally use the German Hodgkin Lymphoma Study Group criteria. There are multiple criteria that one can do, but the reason that we've used their criteria is that many of the trials upon which we make our decisions utilized those criteria. So you can pick your criteria if you like, but those are what we typically do.
And what about that HIPPY score you were talking about?
Yeah, so that actually I think is something that's proving to be really helpful. There's actually an I-HIPPY and an A-HIPPY. So both of them are one is for advanced disease, one is for more sort of limited stage disease. I think they're really just quite sophisticated because they're taking what we already use and just using and refining it a little bit more. So we've started to use that a lot more in our practice. It's the kind of thing where you can just have either, just the website marked on your phone, or you can have it on your computer. Very easy just to dial it in. And it really helps because it has more of a predictive value per patient than it has just kind of global.
And what is the current definition of bulk? Is it 5 centimeter, 7 centimeter, 10 centimeter, or related to site?
Yeah, so a lot of this will depend on who you ask, because there have been different groups that have done different things. I think in my practice, I'm in the 7 centimeter space, where I think when you've got a mass that's greater than that, I would regard that as bulky disease.
in this protocol of Nivo AVD, what is the logic of sequential Nivo followed by AVD and the combination? When to use what? How does one
Yeah,
decide?
so I think, to be frank, that particular study, remember, it was started probably, I don't know, 8 or 10 years ago, as we were just learning about nivolumab and pembrolizumab. The goal of doing it sequential versus concomitant was to actually get a sense of what Nivo did by itself. I think when all is said and done, it doesn't matter. My view is that you could just give the two together and not have to make it more complicated than it should, especially if you're going to take longer than you should to finish the treatment.
And in this protocol, when should one do the PET? Interim
You
PET,
mean the
or should, yeah, in this Nivo AVD?
So my feeling is that once you've completed, you could wait somewhere around 4 to 6 weeks before you do this is end of therapy PET, to be able to really give a little time for the inflammatory changes to kind of wash out.
And how would you treat Hodgkin's lymphoma in pregnancy?
Yeah, that's a complicated question. I will say that over time, we've learned that you can utilize many agents without significantly putting the fetus and the baby at risk. I think there are a few strategies that are typical for me. I think I tend, just as Dr. Agarwal was saying, we tend to go back to drugs we have the most experience with. So we tend to move back into the ABVD spaces to avoid complications that we don't know as much about. But if you can wait, we tend to wait. If you need to go ahead with treatment, actually, even if the baby is being retained, ABVD chemotherapy can be administered. Occasionally, if we could just do radiation, we've done careful screening and then just radiating the most troublesome spot to buy some time. And often we'll also use steroids as a way to mature the baby if it's close to pregnant to delivery, and then go ahead with full treatment once delivery has happened.
And in this regimen of Bracard, how important is it to insist on preservation of the oocytes or the ovary, I mean the ovum, ovarian stimulation?
Yeah, I mean, I think, quite frankly, the likelihood of being subfertile or infertile after those regimens is less than with escalated BIACOP, so that's good. But I will still say it is quite substantial. And so that's the reason that we would typically recommend doing preservation. I will say this much, it could be that in many people, preservation is not necessary. They will have children without any problems. But it's always really devastating in the patient where you didn't do it, and then that's the one who has trouble. Then you would always feel super, really bad about it. So we tend to preserve for everybody, even if we think the risk is extremely low.
Thank you so much, sir.
Thank you. Dr. Karthik.
Good evening, sir. Sir, I have a couple of questions. So, in early stage unfavorable disease, only due to ESR, will we go for radiation or we can go only for chemotherapy?
Sorry, I missed that a little bit. So you said the ESR and then the radiation and chemotherapy?
Yes, sir.
I'm not sure I totally understand the question, but I will say this much. In unfavorable patients, elevated ESR, we would typically recommend radiation and chemotherapy, because I think these are the patients where sometimes there is a greater risk of progression with omitting the radiation treatment. Certainly in our practice, that's kind of what we learned, is that if you're not careful, these are the people where you can actually have disease progression. So if that's what is contributing to the unfavorable characteristics, we would add the radiation treatment.
And secondly, sir, any role of low dose fixed nivolumab like 40 mg with ABD in advanced stage?
I'm sorry, give that to me one more time.
Any role of fixed low dose nivolumab plus ABD?
Low dose nivolumab, 40 mg.
Yeah, that's a good question. So you saw me pause for a minute there, because I don't know that we have a lot of good data around that. I will say that I think we've got evidence that the dose of any immune checkpoint, we're using big doses, probably substantially more than what we need. Exactly what the dose should be, however, I think is a little unclear. So I think you could do that, certainly. It's just I think you're in a bit more of a data-free zone.
Thank you, sir.
Okay. Dr. Shweta Pathak.
Hello, sir. Thank you very much. It was a very nice presentation. I have a few questions, sir. First is, as you said, in bulky disease, I mean, you must give radiation. So I have a 6-year-old boy who presented with HLH and then diagnosed as Hodgkin's lymphoma, bulky disease. So that boy, after 8 cycles of ABVD, he is in complete remission. PAT is negative. So what is your, further plan of management in this child? So do you still recommend radiation in this child? PET negative, initially bulky disease, small child, 6-year-old.
Yeah, so I think, again, many treatments need to be individualized. I think I kind of take the view that I want to try and make my decision at the very beginning as to how I'm going to treat the patient, follow then that treatment regimen, because otherwise it gets a little tricky to know what best to do. In this particular patient's case, clearly we had a complicated course. Well done that you've done as well as you have and got the patient into a complete remission. And now you have a young child where you want to limit radiation and you have a patient who is in a CR, PET negative CR. I think it's quite legitimate in this case now to leave the radiation out, because I think, again, you have a greater likelihood of increasing toxicity without necessarily providing additional benefit. Now, right at the very beginning, if you'd asked me, I would have said I would have planned for radiation treatment. But I think now when you're at the end and this is where things have turned out, I think it's okay to leave the radiation out.
Thank you, sir. One more question. One more boy, relapse Hodgkin's lymphoma. He's 12 years. It's 6 months post-transplant. He is okay, absolutely fine. In between, he had prolonged febrile neutropenia, after which he recovered well. Now, for adolescent patient, what is your plan of management post-transplant? Nivolumab is better or any other better option? This is for adolescent child, sir. What is your experience?
Yeah, so generally speaking, I think when you've had a patient who's had a more complicated long-term course, and now, as you said, if I understood you correctly, 6 months have gone by and the patient has not relapsed, I don't think I would add any consolidation at this point. I would keep agents in my pocket for possible use later, heaven forbid that things show progression. And the reason is this, is that in my thinking, consolidation started pretty much within the first sort of 2 to 3 months post-transplant, is trying to prevent the patient from relapsing. If you've already got 6 or 8 months of time where you haven't seen relapse, you may have a favorable patient that may not need that. I would also say the second thing is we have strong randomized data for the use of brentuximab vedotin as consolidation. We only have 2 very small phase 2 trials of immune checkpoint as a consolidation post-transplant. So in my practice, I tend to keep those agents, but particularly immune checkpoint agents, for later, because you don't want to have used it up, as it were, when you didn't necessarily need it.
Okay. Thank you, sir. Thank you. Thank you very much.
Thank you. We'll take some questions from the audience. Are there long-term toxicities of Nivo?
And the answer is yes. And I think, again, we're now using PD-1 blocking antibodies in many diseases. So I'm sure pretty much everybody on this call has experience. I think things that we're seeing in the long term is endocrinopathies, I think, are substantial. I think particularly thyroid dysfunction, we're seeing a lot of that in long term. I think we don't necessarily have really long-term data around other changes for chronic inflammation, which obviously could well be a consequence of immune checkpoint treatment. I think the biggest issue is just the risk of the cancer versus the risk of long-term complications, and weighing those up. When you have an active cancer that is being treated, long-term complications are kind of something you're not even sure you're going to have to address if the patient isn't long-term in their outcome. So I would say, all told, being aware of things, making sure the patients understand those risks, and I think particularly as we use them in younger patients in frontline, we need to watch for those long term.
Thank you. And the question is, those patients where you use colony stimulating factor, it is pegylated or non-pegylated, and on which day after the cycle you give them?
Yeah, that's a good question. Again, I don't think we have a lot of data that really helps us understand which one to use where. There are some folks that will basically just use a short-acting version and give 3 or 4 days of let's say, Neupogen, for example, in patients after receiving nivolumab AVD or ABVD. Personally, in my practice, I will use pegylated growth factor support, and I will do it every second time. I tend to use ABVD chemotherapy or nivolumab AVD chemotherapy, and I would tend to give it the day after the chemotherapy and then repeat it, not with the next dose, the B cycle, if you like, but on every A cycle, kind of moving forward.
Thank you. The other question from Dr. Leong is, do these modern therapies based on Bricard and Nivo require a port or PIC line, or can we use it from peripheral lines?
Yeah, so that again is a very good question. In our practice in general, we just do it out of the peripheral lines. A lot of it comes down to the patient. Obviously, if the patient has not great venous access, you always want to be able to administer these reliably. So that's part of your equation. And also it comes down to the expertise of your institution and you maybe personally accessing the lines. But in some patients, provided they've got good access, there is no problem in my mind in administering these peripherally.
Thank you. Other question from her is, do you foresee biosimilars coming in place of present PD-1 inhibitors?
I sincerely hope so. I really do believe that we need to be able to have competition in these spaces to really do a better job of driving prices down. And, I think many of these agents are shortly coming off patent, and I'm certainly hoping we'll have biosimilars available.
Dr. Hita has a question. There's a 13-year-old boy, stage 4B disease. Would you go for pediatric-based protocol or the present protocol like Bricard?
Well, that's a good question. And I think, again, I would stress it should be given based on the expertise of your institution. Because if you're the first patient at your institution to receive a regimen that no one is familiar with, that actually decreases your likelihood of a good outcome. So I would say if your typical institution uses a pediatric regimen regularly, use a pediatric regimen regularly. But on the other hand, I will point out that the nivolumab AVD chemotherapy regimen was given specifically for 12-year-olds and older, and the results are outstanding. So I will say that I think these regimens that are more, shall we say, adult regimens may well have merits to bring them to younger patients too. But I think Briacad has side effects and you want to make sure you're comfortable with them. So if you've never used Briacad before, I wouldn't use it first time now.
Right. The other question is, with these modern protocols, is autologous transplant in relapse setting going to become obsolete?
Yeah, very good question. And the answer is don't know. I will say that there are now randomized trials and comparative studies testing that, because I do think patients with low burden of disease receiving these regimens, as you just mentioned, there are actually now a cooperative group study in being done to see whether a transplant can be left out. I would say until the results of that study show up, I would still keep a transplant in my thinking as management.
Thank you. The other question is regarding the duration of PD-1 inhibitors in maintenance therapy.
Yeah, so I think it depends a little bit on what you mean maintenance therapy. So post-transplant is consolidation. I typically don't recommend a PD-1 blocking antibody because we don't have a lot of data related to that. And I personally would keep the PD-1 antibody for therapy at a later point. When you say maintenance, like you treated somebody, you got them in remission, and you want to keep them in remission, that's a good question. And that's actually very difficult to know what the answer is. In general, I will give at least somewhere around 6 months of treatment. If the patient is in a CR, we actually will offer the patient an opportunity to take a break and then retreat if there's evidence for progression at a later point. In a PR, we tend to say to the patient, you help us decide what you want to do. And then to the question we got asked a little earlier, we try and stretch out the time. We don't change the dose, but we stretch the time between the doses to try and get them to a maximum somewhere around sometimes 6 to 8 weeks.
Right. The other question is regarding ctDNA. Has it entered the clinical practice in US?
And the answer is no. It's been done in clinical trials. The biggest thing is just how do you use ctDNA in practice, and how does it change what you would do? So, for example, if ctDNA showed that there was still positivity in a PET negative patient after frontline treatment, would you change your management? And if you would, what would you change it to? And because we don't actually have good answers to the second set of questions, generally speaking, we're doing it really as a learning experience, but not as a practice changing one. So outside of clinical trials, would not recommend that.
Thank you. A patient who has become refractory to both BV and Nivo, will you go for allo transplant straight away?
I would say that once you've got refractoriness to those regimens, I think that is a very poor prognosis patient. And allogeneic transplant remains a reasonable consideration in patients. So we always will consider that. The biggest challenge is to make sure that you've got a very low burden of disease before you go to an allo. So going to an allo in a patient who's relapsed, who still has bulky or residual disease, those never do well. So when you have refractoriness, it's quite hard to get a patient back into a good remission. So then you might need to go back to old school chemotherapy and then go to an allo after that.
Thank you. The question is about elderly people. Can they be cured without chemotherapy with modern drugs?
So that's actually been tested. We actually did a clinical trial of nivolumab plus brentuximab vedotin alone, just those two agents. And the answer is yes, they can, but the number of patients with long-term durable remissions is probably in the 25 to 30% range. So a lot of patients, unfortunately, progress. So I would say the nivolumab AVD chemo regimen has been very well tolerated. And then the progression-free survival is like 85%. So we tend to try and use that as our preferred regimen. Sometimes if the patient is a bit sick, we'll do just nivolumab alone to get the patient in better shape and then go with Nivo AVD after that. That I think is also legitimate. If the patient absolutely cannot receive AVD chemotherapy, then I think you've got a complicated patient, and then I think you just do whatever you can.
Right, sir. Next question is the information on AI interpreting and predicting the response rates from morphology is fascinating. However, is there any genetic marker by IHC or sequencing underway to predict the 70% as you mentioned?
Yeah, so again, good comments on both of those. You saw me show the data right in the beginning of the ctDNA analysis. And I think one of the strategies that's being tested there is to say, can you use peripheral blood ctDNA as a way to predict response to various therapies? And in those studies, they were looking at outcomes by ABVD or escalated BIACOP much more than the newer regimens. So I think there's going to be data coming out that may be informative. As relates to the morphology, that's actually a AI program called LymphoVision. And it's kind of really interesting because I actually think that's going to help to democratize our treatment approaches for patients. And, is really now, it was developed in the US, but now it's being validated in the German Hodgkin Lymphoma Study Group data to actually see whether we can get a correlation between the image and patient outcome based on treatment.
Thank you. The last question is, does rebound thymic hyperplasia trouble in assessing the response?
Absolutely. So again, you working with your radiologist if there are any concerns, and to get an assessment of that is really important. We see patients not infrequently in our practice sent to us with reported relapse in the mediastinum, and it ends up being thymic rebound. So I would say if in doubt, a biopsy is very important. Also, I would say time, because if it's Hodgkin lymphoma, it will become worse. If it's thymic rebound, it will generally become better. So sometimes another strategy is just to wait another 2 to 3 months and then re-image and see what is changing.
One question in between was about nodular lymphocytic predominant Hodgkin lymphoma, advanced stage. What is your initial treatment today?
Yeah, so I think that's, again, very important question. And I think that I would regard as a low-grade lymphoma and think of it very much more like follicular lymphoma than like the classical Hodgkin lymphoma we were talking about today. So what is my approach? Just like follicular lymphoma, I think of it sort of in the how much do you have to do right away versus can you watch? Can you give radiation treatment just to single spots if there's just a small amount of disease? And then after that, more of a kind of a lymphoma type approaches. So we tend to use rituximab plus chemotherapy as the treatment for those patients.
Thank you. So that finishes the chat box. Any questions from anybody here? Okay, sir, thank you very much.
Thank you very much. Appreciate the invitation.
Enjoyed. Thank you. Thank you.
Bye-bye, everybody.
Is Inta's team here for the vote of thanks? Usually they aren't there at the end of the.
They are not there.
They are not there usually. Okay, bye-bye, everybody. Have a wonderful time.